Questions? Anyone got any questions? We can take them orally or we can take them written, if you like. Yes.
Well, we once actually we ran some of the famciclovir trials here, and we actually put up a protocol to look at 72 to 96 hours, and unfortunately didn't get funding to do that, so it's never been looked at formally. But if you look at some of the AHMF guidelines, I think the feeling here is that there is no hard evidence on this, but obviously if you have a patient who's still developing new lesions beyond 72 hours, they're still getting virus coming down and replicating in the skin, which is potentially susceptible to antivirals. I think one of the really interesting things is going to be whether we can actually show whether subacute or subacute pain or post-herpetic neuralgia really is associated with ongoing viral replication, a little bit like herpes simplex encephalitis. And I think some of these studies using quantitative PCR and saliva are of some interest, I think, in the future. So I haven't really answered your question, but I think that most of the people I know around the world would actually treat people with severe zoster, particularly with severe prodrome, if they're between, say, 40 and 50, because you can get post-herpetic neuralgia before the age of 50, although it does tend to, you can see, I think by those graphs that I showed, there were some people under the age of 50, but it certainly accelerates over the age of 50.
Bill? I'd just concur with Tony. I think the big thing is whether they're getting new lesions, and it's my practice to do exactly that and to recommend it because it makes sense, and the reality is the trial's unlikely to be done exactly as Tony says, and you're never going to get that evidence, but if your virus is replicating, then your nucleoside analogue should be working. To recognise it, the best thing is a nucleic acid test, so a PCR or whatever you've got, and increasingly we're now doing viral load for CMV initially because as they become cheaper it's just as easy to do it and you get your answer more quickly. And to monitor therapy we use blood levels of CMV, so we do viral loads. The question of whether you do viral load on cells or on plasma, we've now had a study running for a couple of years, and there were several published studies. Well, there's only a couple of published studies which look at cells versus plasma, and in immunocompromised patients you often find virus in the cells at very high levels, 50,000 copies per mil of CMV, and the patients are perfectly healthy, so its correlation with disease is very poor. And yet the same patient who's healthy, their plasma level is 0, and it's not until their plasma level goes up that they develop disease. And so plasma viral loads we use as the best marker of likely disease.
Yes, well, I think that's an interesting question. Of course, you can get T-cell boosts because, as I said before, mothers who are exposed to their children with chickenpox, and Arvin showed this quite clearly, get T-cell boosts. And what we're trying to do here is exactly that is boost their T-cells. And the interesting question is how long that will last. It looks pretty good at 4 to 5 years. There's a plateau. So we're hoping that this will last for quite some time, and that's the reason for using such a high concentration of attenuated live virus, which of course replicates in the presence, and you probably well know that if you've had herpes on the mouth, you can still inoculate yourself and get herpes elsewhere in the skin. That's just an example of the fact that the immunity is not sterilizing in this case.
Look, I think the first question about CMV and HIV, I mean, there's been papers for 15 years looking at transactivation, and there's no doubt that some of the proteins that CMV produces transactivate the, particularly the LTR, basically the replication machinery of HIV. And also, secondly, there's no doubt that the immunomodulation that CMV does to an infected cell in terms of down-regulating class 1 and affecting a number of the cell surface markers, you would think would increase infection of those cells with HIV. So it's interesting. There's not more. A lot of that work sort of stopped. It was done, and then there hasn't been, with all respect to people who do it, to my knowledge, there hasn't been as much work done recently. The second question was about, part of the question was about if you treat CMV, would your HIV do better? It's gotten a number of our very senior colleagues into some difficulty, this area, because it tends to get in the newspapers before you're ready. You would think that it would, and if you had a non-toxic CMV agent, then using that agent would perhaps do that. But the problem is, if you give enough valganciclovir, let's say you did a trial with valganciclovir, if you give enough valganciclovir to get the same levels you get with intravenous ganciclovir, you get very similar toxic side effects. And so it's unlikely you would see much benefit because you'd be right on the edge. Could you do one with valacyclovir, say, which we know reduces the amount of CMV, but it's not a great CMV agent, but prophylactically does appear to reduce the clinical problems from CMV, and that would certainly be a study, but I've not seen it done.
I think, though, with herpes simplex, as we heard from Andrew about the Nagato study, the Nagato study confirms earlier studies from Corey's laboratory that actually show that indeed herpes simplex not only increases the amount of virus being shed. I think that's a biological phenomenon related to CD4 lymphocytes and macrophages in the lesions, which we showed some years ago, not a molecular phenomenon of actually cross-transactivating. The two viruses don't really find themselves often in the same cell. But there was also an increase in viral load, albeit small, and I think that's an interesting question about how significant that is. And in fact, the Nagato paper concluded with speculation about whether this was significant or not.